Hi, Dr. Barry.
Hello, Darryl.
Thank you for being in our conference today. Can you tell our audience who you are and what you do and where you do it?
I sure can. I'm a professor and a nurse scientist at the University of Washington. And my whole career has been dedicated to helping people with cancer communicate better with their doctors and nurses and take care of themselves with using different techniques for self-care.
We are here to talk about how you make a decision. I guess the best place to start is perhaps a patient walks into a doctor's office. The doctor says hello, patient says hello, doctor says, I see you have prostate cancer. Patient's now expecting the doctor to say, I think you ought to do X, Y, or Z. But the doctor's not going to say that. Why is that?
Well, typically not, because most of the prostate cancer these days that is diagnosed is at such an early stage and has such a good prognosis or promise for the future. I like to say the prognosis is that the doctor usually explains a whole list of options from a menu and then says to the man, what would you like to do? And that's a really scary question because this man has just been told he has cancer. And perhaps in his life, he's heard about other people with cancer, and he thinks that the best thing to do is just get rid of it. So, but that's not the case with prostate cancer. We know that there are more options than just removing the tumor. So I like to call the prostate cancer decision the archetype or the scariest decision of cancer that there is.
Right. And it's the one that sort of lays the foundation for the rest of the guy's life, rest of all of our lives, not just the man, but everyone in his family, everyone who cares about him. The idea that there are all these options, it doesn't, I mean, the scary part isn't so much that there are options, but the scary part is that there's no real way to choose among them. Is that fair to say?
Well, there is a way to choose. Men make their decisions using a lot of personal factors. What that means is what's important to them has a great influence on their treatment decision. What people have done in the past that they know, other people that have cancer have told them stories, and they use those stories to understand more about the decision that they're trying to make.
Let's just back up just a teeny bit. The idea of what these options are. I mean, most people in our audience know we're talking about radiation, surgery, and all the different flavors of that, as well as HIFU, high intensity ultrasound, focused ultrasound, and perhaps cryosurgery, where you freeze things, and lots of other ways to do things. Part of what underlays all of this decision making is sort of the extraordinary idea that for most men presenting with an early stage prostate cancer, and we will talk about advanced stage prostate cancer in about 15 or 20 minutes, there's no certainty to the outcome from any of these particular, interventions. Can you talk about that a bit?
Right. I would say there's one exception to what you just described.
Okay.
So there are a group of men who have localized prostate cancer for whom, when the tumor is looked at under the microscope, the pathologist can determine that this is a more aggressive type of tumor. And for those men, the use of any kind of active treatment, we know has a better outcome than active surveillance. But the flip side of that news is that these are the minority of men. The majority of men have a favorable prognosis, we say. They don't have a very aggressive type of tumor. And so they can choose from various treatments, including active surveillance, which is a very rigorous way of monitoring the tumor using a protocol that involves blood draws and biopsies again after the original biopsy. So I just want to make that qualification that the majority of men have all the options laid out in front of them. But there is a small group of men who have an aggressive tumor for which we know active treatment has a better outcome. So going back to your question, how can men possibly understand all these different treatments? when we compare one active treatment to another, we basically get the same results from those treatments. Even compared to active surveillance, there's very little difference in men who truly have a low risk tumor that's localized to the prostate.
Okay, so we have the opportunity to have equal odds of a favorable outcome.
Yeah.
Okay, but that's also to say we have equal odds of an unfavorable outcome, which is to say we don't know what kind of outcome any of these therapies and treatments will offer a guy. And at the same time, the reason we're discussing any of this is because of the side effects of all these treatments. And, as we say in our support group network, if this was just about pulling a wisdom tooth or cutting off even, perhaps losing, use of your left hand, we wouldn't be going through all the trouble of doing support groups and running a national organization. I mean, that's just the price you pay for the best possible treatment in the year that you're getting treated. But we're talking about impacts on quality of life that for many men are extraordinary and devastating, and certainly limiting to their ability to maintain a level of happiness and productivity and just a joie de vivre that makes them wake up most mornings with a smile on their face.
Yes.
So we're talking about treatments, side effects, and basically we don't know what's going to happen, but something will happen. What have you found that helps men actually figure out what to say to the doctor? I'd like X.
So we found out that some men are very concerned about the infamous long-term effects of surgery. For example, losing the ability to have an erection, losing the ability to control your urine at both of these things at the level it was before surgery. And so some men are very concerned about that. Other men, it's low on their priority list. For example, I've had gentlemen tell me that, losing the ability to have an erection means nothing to them. They've had 4 kids, they're divorced, they don't have a partner, and they don't really care about that anymore. Other men, it's very important to them. They've just been married for a second time and they're looking to have a new family. So the scope of how important these side effects are is very wide for a great number of men. And then with radiation therapy, there are long-term side effects to radiation, not as many as there are with surgery, but there still can be some pretty serious. Well, men are concerned about these side effects. And men are even concerned about, we wouldn't necessarily call it a side effect of active surveillance, but there is a phenomena, there is an experience that men have with active surveillance of having anxiety about knowing that a tumor was found inside them, a very small and non-aggressive tumor, and knowing that they're living with it and it's still there can cause men great anxiety. Some men, no anxiety. So it's really interesting that different men have different fears and concerns, and they're influenced at a different level by these factors. I also found that men are very influenced by what's happened to people in their lives. One man told me once that his mother had a bad experience with radiation when she was being treated for breast cancer. And so he didn't even want to hear about radiation. And this drove him to another treatment or another option. So this is what I've discovered back in the late 90s and early 2000s, that these personal factors are very important to men and that we can't just ignore them. And so when they go in to see a doctor for this options review talk, I call it, being able to talk about what's important to them, to these men, is critical for making a decision that's going to match their personal preferences. So that's what I embarked upon, is a way to help men think about these different side effects, think about who they are and what they want and what they do, both for work and for recreation, and put that all together with the medical facts that basically say you have little chance of having a recurrence or dying of this prostate cancer in the next 5 to 10 years. Very little chance. What do you want to do in the next 5 to 10 years based on what's important to you?
Yeah, and what you're describing is really sort of, it sounds like there are two different funnels going on in a doctor's office. Doctor is asking, would you like radiation? I have a radiation oncologist. Would you like surgery? I could set you up tomorrow morning or whatever. Would you like X, Y, or Z? And sort of like, can I fix your brakes or, get your ignition started? The man is really saying, well, I want to be able to have sex tomorrow, and next year. I want to be able to be intimate. I want to be able to have the same level or greater energy in a year than I have today. I want to, in other words, the doctor's asking about medical stuff, but the man wants to be asked, like, what's your life about?
Yes, exactly. And the best doctors will solicit or ask for that information, but not all of them do. Some of them think their job is to lay out the options and then turn it over to the patient without getting that information from the patient. So we developed this program to supplement the talk that the man with prostate cancer and his partner are having with this doctor, to supplement that.
So, and we'll invite folks to try out your thing in a minute, or we'll tell them where to go for that after this talk in a minute or two. But what can something external, what can you do seated in Washington, at the university, and there are men all over the world, what's available to actually get doctor and patient talking in a way that will make everybody, both of them, happy as a consequence of whatever they're about to decide?
Well, we like to think that what we've done is to promote shared decision making. And you might ask, well, what is shared decision making? It's when the decision is based on those personal factors as well as the medical facts. And the doctor and the patient together come to consensus about what's best for that individual man. And that's what we call shared decision making. It doesn't mean that the doctor makes the decision and says, here's what you need to do. And it does not mean that the patient walks in the room and says, I am doing nothing but having this certain treatment. Those two examples are not shared. It's when the conversation comes together and the doctor and the patient make their decision together. That's what shared decision making is. We know from research around the world that the more shared the decision is, the higher the satisfaction with the decision is afterwards. That if men participate in making that decision, not only are they more satisfied, they have lower regret levels. We've done this, I've done this research, others have done this research. We know that it works. And if you provide a way to coach men on getting into shared decision making, we know that works too. And it can increase satisfaction, lower regret, and reduce the conflict that men experience with this great decision.
Yeah, and brilliant that you use the word regret and mention the studies that support that. For like 15, 20 years, our organization started with the premise, there's nothing that we can do to actually, we're not doing surgery. We're doing psycho-oncology, we're doing support services. We're basically, rubbing shoulder to shoulder with a bunch of guys saying, all we're going to do is help you get to a place where you could die without a moment of regret, where no matter what happens 5 or 10 years from now, you're not going to beat yourself over the head with a baseball bat or any kind of stick, wondering, did I miss doing something, 5 years earlier or 10 years earlier? That's all this is about. And even though that's all this is about, as your work has clearly shown, and good that you've sort of distilled some, an instrument that's quite useful, it's still a challenge for guys because they're still walking into an office where the other person on the other side, man or woman, has an MD after their name, and sometimes an MD and a PhD and a bunch of other letters and such. And, we expect them to know better than us. But the challenge is they don't know us.
No, no. So I want to make one more comment about regret.
Yeah, go ahead.
We found over the years, myself and other investigators, that African American men, they have higher regret than white men, and they are diagnosed more often with prostate cancer than white men. So this is a really important focus that we need to have. We have found that if you can coach African American men to present their personal factors to their doctor, we can lower their regret even more than white men. And I think that has to do a lot with our social determinants of health and what happens in the healthcare system with people of color. But Black men with prostate cancer can be helped and coached to get to a level of low regret and satisfaction, just like white men have been. So I just wanted to make that point because it's so important that we address these disparities up front.
Right, and just to clarify, you said that Black men are diagnosed more than
often.
White men more often. I mean, are you saying that there are more Black men with prostate cancer in the United States than white men?
Per capita. Well, we don't have.
Right,
it's per capita of African American men. More of them are diagnosed with prostate cancer than the percent of white men.
Right. I mean, worth clarifying so people aren't, freaking out about that. And, okay. I mean, we should freak out about it, and
it's important.
Right, and we have the Black Prostate Cancer Alliance that's entirely focused on that disparity issue and racism in the healthcare field as one of the larger inputs that cause that. But I mean, we don't want to be saying, there are more Black men than white men with prostate cancer in the United States. I don't even know how to express it statistically, but that's the clarification I just want to make. Yeah. Anyway, So actually, and forgive me if this sounds provocative or even rude, but how is it that a white woman is focused on, has created something that helps Black men around prostate cancer?
Well, I didn't create it myself. I talked to a whole lot of men with prostate cancer, including Black men and Latino men and white men. And everything they told me has informed how we've developed this. We have a whole team that works together. We've just updated our program. We have, clinicians from all races and ethnicities to work with us on putting together the best support system we can for men. Why me? It has been my clinical specialty to work in genitourinary oncology. And so that's where I get my clinical background. And I'm very dedicated to eliminating those healthcare disparities and making all men diagnosed with prostate cancer, making them comfortable talking to their doctors about this decision. So what we've developed provides a coaching mechanism. So it's the most normal thing for them to talk to their doctor about not wanting to wet their pants when they're hiking after their treatment.
So tell us, like in 3 minutes or less, or 5 minutes if you'd like, what is it that you've made and your colleagues?
So we've been able to develop a support system called the Personal Patient Profile for Prostate. And in this system, it provides a questionnaire to the user to ask them what's important to them. to ask them who they are and what they do and what are their top concerns. And then based on their answers, we give them a personalized instruction on what does that mean. For example, if you're most concerned about survival, we provide the survival statistics for men based on certain treatments, based on certain pathology, whether they're high risk or low risk, even within the localized prostate cancer diagnosis. Some are more higher risk than others. We show them graphics. We use infographics. We use video clips of about 15 seconds showing a man that looks like them. If the user is over 65, we show an older man. If they're under, we show a younger. If they're Black, we show a Black man talking to their doctor. And we show these video vignettes so that a man gets the idea of, this is what I need to tell my doctor. We promote them sharing the decision with the doctor. And then we give them text and teaching tips and lots of background about everything they're concerned about. But it's personalized to their age and race, and it's completely translated into Spanish. So Spanish speakers all over the world are able to use this as well as English speakers.
Are there provisions for gay men and bisexual men and the concerns they specifically have?
We haven't developed that module yet, but it is on the scope of things we want to do once we get a little bit more money to redevelop the program. We just updated it.
Do you think that gay men should just be waiting for that module to be developed, or
I think gay men have very similar concerns when it comes to a prostate cancer decision as heterosexual men. There are, of course, specifics about what a gay man would be concerned about, but all gay men are probably concerned about intimacy and survival and incontinence as they are as heterosexual men would be. So I think it's usable by gay and even trans women who still have perhaps a prostate. So I wouldn't say that it's not applicable. I would say it absolutely is, even though we don't have a special module right now.
Okay. Do doctors use this?
Well, they receive the report. They receive a one-page color graphic report of the top concerns of the man, and they can see at a glance what's going to be part of the conversation that they have with this gentleman when they go over the different options.
So and this P3P is what it's commonly called?
Yep.
Okay. And of course it has the PP kind of, alliteration kind of thing. So it's a good mnemonic for it. The idea of a doctor getting a printout, I mean, does that actually play out in a consult?
Yes. And some of the feedback I've gotten from the doctors is, for example, one said, it's like having a window into the exam room of what's important to my patient. I can look at this and in 60 seconds, because it's color graphic and slide bars, I can see exactly what's the top concerns so that I can go in and I can share that decision. But I love the metaphor of a window into the exam room. The doctors that have used it think this is a very helpful tool for them as well.
Yeah, and why isn't this used as just a standard part of the intake process or something similar to it?
Well, it is being used in a few places. I think, P3P is not unique in when you ask the question of why is this used or not. Number one, the hospital or clinic is not going to make money off of it necessarily. So there's no charge to the patient. There's no billing system for this. And so without making new money for the clinic, maybe it's not a priority for them. Number two, it's very hard to change the flow of practice. And so for a clinician to say, wait, before you come see me, I want you to use P3P. Now that does happen in some clinics, but not all clinics. How do you get every man in the every physician who takes care of these men in the United States to recommend it? Well, you promote this, you talk about it, you advertise it, you present it at professional meetings. But I've decided, one thing is that we really just want to put it out on the internet for men to use. And whether the clinician recommends it or not, men can use it. And so we have many, hundreds of men that are using this over time on the internet, as well as being recommended this on the clinic. So it's free, it's easy to use, and it's been tested so well. We know that it works well with American men. We have not tested it in Canada or England. It has been used in Australia, and it went well there when it was used. So we feel very confident that this is helpful to men, and we have the statistics to back that up.
Have you seen like more men using it as a consequence of COVID?
No, I would not be able to say that. So no. That's an interesting question, though.
So, and I encourage, try it out. I've tried it. I'm sure everybody will find a quirk here or there, but it's a useful exercise, if not an actual tool to go through, just to provoke an idea or two about yourself that you haven't thought of prior. The idea of spouses, caregivers, husbands, and wives of men with prostate cancer, is there any value for them around an instrument like this?
Well, we recommend that spouses and partners listen at the same time to the coaching. And, it can be used on a smartphone, turn the speaker on a computer, on a tablet. The answers to the questionnaire in the beginning should be the answers that the man himself gives. A partner could guess at how important these factors are, but they are personal factors for that man. So we think it's helpful for partners to listen to the coaching and the video clips and read the text that's provided, that's tailored to that man's concerns.
Yeah, and there was a recent journal article, tested 12, I think, similar kind of projects, decision-making tools. And if I'm going to mischaracterize how it's said, but I'll try. The idea that, there were three problems they found. One was around language, whether it should be a sixth grade level or, at Malecare, we do everything at a fourth grade level because that's all I can understand. So if that's all I can understand, that's what it is. But there was another issue. And then the one thing that I found interesting, they looked at something around the idea that these decision tools don't accurately portray clinical settings and clinical outcomes. They don't describe treatments as correctly as a physician might. And what roiled me around that was that's really not the purpose of tools like this. It's about presenting who the man is to the doctor. Don't you, what do you think of that?
I think you're right on. That's the important thing, is what is going on in this patient's head that's important to them, getting it out of their head and into the conversation with the doctor. Because the doctor is the expert in the medical facts and can easily review very accurately what's going on from the medical standpoint. But bringing that together is what's so important with those personal factors. And providing education to men about the different treatments we've tried, we feel very good about the information we provide, that it is accurate. And like I said, we update it on a regular basis so that, it has the most recent infographics and statistics. But really, it's the promotion of getting the sharing of what's important to the patient and what the doctor can give as information. So you're right on with your with your criticism.
Yeah.
Yeah.
Do you think that there's a significant percentage slash majority or close to of doctors or urologists and medical oncologists, et cetera, that are just afraid to get to know their patient?
I don't think it's afraid or fear. I think it might be time constraints. Like they have this man booked in for a certain amount of time, and they feel like if they jump into trying to get the story of what's important from that man, it's going to eat up too much time. I think that might be a concern. And that's exactly why P3P can be used ahead of time, because it helps facilitate the sharing of that information. And it gives the doctor the window into the exam room of what's important to that man before they even walk in.
Yeah.
So
How do you think P3P would play out for a man in advanced stage prostate cancer, a man whose initial treatments were inadequate?
it's really geared, P3P is geared for localized disease. We don't include any infographics or statistics on advanced stage cancer. We really need that. That's really something that's needed. I have tried to get funding to develop that, and I have not been successful. I won't give up, but I haven't yet. So the concept, I want to say though, the concept of of a doctor understanding what's important to a particular patient when they're in the room, those personal factors are still at play with advanced disease. There is no question about that. But I must say, with the advanced treatments, there's a little more certainty and outcome. There's not as much equivalence between the different treatments in advanced disease. So there may be a stronger recommendation from the clinician that goes hand in hand with what's important with that patient.
Yeah. So it's a shame that today and going, 2022, perhaps even 2023 and beyond, the burden of expressing who a man is, the initiation of that conversation is the burden of the man. It's not part of the intake. It's not part of the consult necessarily. Shared decision making, we know from our support group members, there's nothing really going on around that in a dramatic way. Doctors I talk to, I ask a simple question, have you changed the way you consult with your patients, at least initially, than, let's say 5 or 10 years ago, and nobody says I've made a big change or anything. I'm doing it just as brilliantly now as I did then. It's like who we are matters, and the only reason we're going to a doctor is because we want to do more of what matters to us.
Yeah.
So any last words as we close this out?
Well, I think in every healthcare situation, and very much in prostate cancer, being able to tell the doctor what's important to you, what you're concerned about, what your personal values are, all of those things are critical for making a healthcare decision, not just prostate cancer. You are a whole person. There's more to you than that tiny slice of time that you spend in the doctor's office getting that consult. And all of that, what's about you as a man, needs to come forward when you're making a healthcare decision. And for women too. But I know you're Malecare. You're focused on the men right now. But for women, it's same. It's the same.
Yeah, and we take care of transgender women. So there are women in our audience. We tend to regret naming our organization Malecare in some respects, but we're glad ultimately that we did, because there's nothing like it. I mean, there literally isn't anything like it. And yeah, I mean, it's good that we're emulated to some degree, but not as much as we'd like,
Well, I'm really glad you're there.
Thank you. And we're glad you're there too. And I want to thank you for your investigations, your research. I've read 2 or 3 at least of your papers, if not more, over the years, and your work around the P3P and just the opportunity for men to have some quiet time in front of their laptop, trying to figure out what they want the rest of the course of their life to be, and to feel encouraged to express that to the doctors and nurses as well. Nurses are important caregivers in the healthcare setting as well, and social workers, why not? So thank you very much, and thank you for being part of our conference today.
You're very welcome.
Okay,
Good
bye.
care. Bye-bye.